Welcome to the LiveLong Podcast, where your health is your power. I'm your host, Rachel Lehmann-Haupt. We have a very special guest, Dr. Krista Ramonas. She's a double board certified physician and surgeon, and she's the founder of a San Francisco concierge practice focused exclusively on female longevity called LabXMD. Welcome, Krista.
Thank you, Rachel.
So Krista, I'm just going to jump right in, and then we can also get a little bit into your background afterwards. But I want to know the big question that everyone wants to know, which is what is traditional medicine missing for women who want proactive longevity care?
Two things. One, data. We know all the research has been done on the 70-kilogram white male, and that the science only loosely applies to women. So we're starting to collect data on women, but that's going to take some time. The shift that needs to happen is we need to be okay with what I call evidence-informed medicine. This allows us to make decisions for women now. Evidence-based medicine is the traditional 20-year-long randomized control trial, and we don't have that kind of time. We're starting that data collection, but the process needs to start now.
Yes. And the story is that traditionally we just have not collected data on women. And it didn't start, or it wasn't mandated until like 2015 or something, right?
And everything's skewed as a consequence. Vital signs are skewed. What's the upper limit of normal for blood pressure is totally different for women. Lab values, all the lab values, when you get your Quest or your LabCorp report, those are all for men. They're different for women. So in my practice, we have guidelines in terms of range of normal that are entirely different. Some are only a little different, but they're different enough. And the difference is important because the devil is in the details. The second thing I just want to highlight that I think is missing are trained clinicians. Women need and want this type of care, and there aren't enough of us trained to do the work.
So where does the traditional healthcare system fail most often for women now? Because, the majority of women can't necessarily afford concierge care. Although, for example, I would love concierge care because the more and more I understand it. But so where does the traditional system fail, and how can women, be proactive of their health from a concierge model within the traditional system?
The answer to that is time. Women are mindful of their health more often than men. In fact, studies show that women are more likely to follow up for vaccinations. They're more likely to be proactive about screening for cancer or diabetes. Women are great when it's a one and done. When it's an appointment that requires multiple follow-ups or multiple places to go to access the care, it becomes more difficult. And this is because women are the caretakers. They're taking care of aging parents, and similarly, they're taking care of children.
The sandwich generation.
Exactly. So they're really strapped for time. They're stretched much too thin, and this fragmentation of the system just doesn't serve them. So we really have we have a need to do better. Another area in the data where women fall short is they are typically doing double the amount of housework that men are. So as a consequence, they don't have the time to engage in the leisure activities, the social activities, the mind-body activities that we so often stress. So it's a combination of the multitasking and the lack of the social framework that fails women.
And what do you think the cost of this failure is at 65 or 75? Like, I'm 56, from the age 45 to 55. What are the things we're missing, and what's the cost that's going to affect people, starting at 65, 75, 85?
We're missing everything we just talked about. Access to care, appropriate data, trained clinicians, time for women to access this care, and the number one consequence is dementia. As estrogen drops in the perimenopause transition, it triggers accelerated brain aging. And women, as we know, make up 2/3 of the patients with Alzheimer's disease. We used to chalk this up to, oh, women just live longer, but that's really not the case. The three most important areas that lead to dementia are: one, genetics, we can't affect that; Two, the perimenopause transition, which we all go through, all women, and we can affect that with estrogen. And three, lifestyle. And the limitations on lifestyle for women are just exactly what we discussed. Because of the burdens placed on them in society, they really are limited with the multitasking that they're forced to do to properly engage in lifestyle. So the
So it's
main,
like we have I'm sorry to interrupt
no,
you.
I'm sorry to talk over you. The main consequence I want to really highlight and bring it
Yeah.
to a big headline is dementia.
Yeah. Yeah. You do notice that women start, whether it's Alzheimer's or just generally losing their memory, it happens more often for women. I see it in my own family. My dad didn't live as long as my mom, and my mom is living longer, but her memory is fading.
We also know that women in the generation where they're opting out of work and they're the primary support for their children, that they lose a sense of purpose, whether it's at home with the children or when it's the children go off to college. Um, Without a sense of purpose, we can turn to coping strategies that are sometimes unhealthy. And a lot of the time, this involves alcohol, which is a big risk factor for dementia
And you see that coming into through your clinic.
all the time,
That's fascinating.
all the
Um,
time.
what would you say, a woman like me, a woman in your practice, should start tracking or advocating for differently now?
Specialty care. I think many people get hung up with concierge primary care, but it's really specialty care that we're missing, especially in a city like San Francisco. So, if you live in a large city, you have access to specialty care at every level. And asking for this level of care is really critical. I think this highlights training and understanding where your doctor trained, what degrees your doctor has. There's a lot of confusion, and it's even been highlighted lately in the media in terms of what people call themselves and how that's confusing and what board certification means. And having a better understanding of this is part of my messaging. I really want people to understand, for example, that there is board certification in longevity medicine. Not everyone chooses to pursue it, but the best thing you can ask your doctor is where they trained, what their area of expertise is. And I think that's a great place to start.
And tell me how your practice in terms of specialty care, which is a really interesting perspective to look through because everybody's often talking about the fact that there's so many failures in primary care, which is why concierge exists to create a primary care. But what you're really arguing is the opposite. And I'd love to hear how your practice approaches that.
Thank you for highlighting that. I do argue the opposite. I get frustrated when I hear the system is broken, the system has failed. We live we live in the United States. We have the best healthcare in the world. People fly to us from all over the world. And are we fragmented? Yes. Do we need to do better? Yes. But our physicians are the top in the world. So it really frustrates me when people sort of bang on the system. What I do think is the specialists haven't been loud enough and proud enough. Concierge medicine was captured by primary care for the last 20 years. And then the patients were from that level of care directed to the specialist or the subspecialist who remained in the traditional system.
So it was literally like a hotel concierge, like your primary,
Exactly.
which is sort of
Exactly.
what in traditional medicine your primary care doctor does too, quite frankly.
It is, but should it be? I would argue that primary care is sick care. And that is a model that has shifted, and I'm not really quite sure why. Primary care, what I mean by that is you see your primary care doctor when you have a sore throat, when you're worried you might have the flu, or you worried you might have COVID, maybe you got bitten by a dog. Um, but it's shifted in a way that's somewhat confusing to me. My messaging as a surgical subspecialist is that specialists have the knowledge and the power and should be stepping out of the space into their own to recreate the doctor-patient relationship.
So is that what you do at your clinic? Is that when people come in, they immediately, are assessed and directed to specialists within your clinic?
No, I am myself as a specialist,
Yeah,
use my specialty training within my practice. So, for
understood.
example, I'm board certified as an ophthalmologist. So behind me, this is a retinal scanner, an AI-based retinal scanner. There's a field of ophthalmology called oculomics, which is really going to lead in advanced diagnostics in the future. So, my argument isn't that you should refer only to specialists or subspecialists. It's that the specialist with the specialty training should recreate the relationship within concierge medicine.
I understand. So, what do you think? I just want to turn to testing because in longevity medicine, it seems like, testing, genomics, blood tests, scans are what everybody's talking about right now. And I want you to tell me from your perspective what you think is like the most overused or sort of unnecessary test that's hyped in longevity medicine.
Biologic age testing. Have you heard of that?
Tell me a little bit more. Yes, I know, but I think our audience would want you to unpack it a little bit more.
And I want to be careful about this because biologic age testing, which I'll unpack in a minute, is not useful clinically right now. There is a lot of future hope for this testing, but it is scientifically at the bench for researchers incredibly useful. We're just not there right now. So, biologic age testing would be, for example, I'm 51, but I want to know what's my pace of aging. Am I aging like a 40-year-old or am I aging like a 60-year-old? And where do I want to fall in that spectrum? In longevity, we'd like you to age 7 years younger than your chronologic age. That's our goal. We don't expect you to be 20, but we look at using these tests methylation markers. So DNA methylation falls within the rubric of epigenetics. And all of this science is terribly interesting and really important. When I started my practice in 2021, I used to use this testing more frequently. And I think it's what I found was it was very useful for men and less so for women. Why do
Tell
I
me
say
why.
that? Yeah, it's a good point. Men tend to be more biohackery, they're more competitive with one another. Women are more practical. They just want to feel better, they want to look better, they want to shine in their family. They don't necessarily have a need to keep up with their neighbor, so to speak. So if it's a motivational tool for you and it's, finance is not restricting, we'll test it. There's no harm to it, but banking on this kind of testing is really it's too much too soon.
Well, that is incredible. That's a topic that I could unpack with you for hours, biological aging, and I think we should probably talk more about this at some point. Maybe at the summit we can
I,
talk about
I'd
it.
love to. There are a lot of really interesting tests in this space. For example, I recently did my what's called glycanage, and that's coming out of the UK. By the way, I have no relationships with any companies, supplement or otherwise. And um, we just got my score back yesterday. This is a newer category called proteomics, which I do find scientifically interesting. So there is a lot to say here.
Yes, glycanage. I think I saw the person who runs it on a panel at the Buck Institute
Hmm.
conference,
Exactly
and
right.
it looked like a really interesting panel, a really interesting test.
It's a shift from the traditional DNA methylation markers more into the inflammatory markers, what's
Right.
in the zeitgeist now, which is inflammaging, which is what we're all looking at. So it's fascinating.
Yes, inflammation is seems to be the buzzword. Is it a buzzword or is it for real? Like,
Somewhere in between. Like a lot of the testing, it's somewhere in between. It's all personalized. I think the difficulty I have with this testing is this. It's not that it's not interesting. There is real science behind it. I love the people behind many of these companies, but many women are coming to me saying, "What's BRCA? I've never heard of that." And yet they want their glycanage, right? So this is the problem. We're going high level when we haven't fixed the foundation.
and BRCA, just for people that don't know, is the gene that will tell you if you have a higher chance of breast cancer. So you're saying that testing for that gene is much more important than testing for your inflammaging metric.
Absolutely. Let's look at, so my background is in oncology. I did a fellowship in ocular oncology at UCSF. Cancer is one of the top five causes of death and a big concern for women when they're starting menopause therapy, which we know it shouldn't be, but it still is. So I really focus on the basics before we talk about the sexy, more elevated, newer testing. So yes, cancer genetic testing is something every woman should have done.
Wow. And it's funny, you bring up, every woman's feet. There is still, even though, the black box label has been taken off hormones testing and that, now it's sort of okay to take estrogen, there's still a lot of fear about it. And there's still a lot of fear, particularly around cancer.
Well, I hope I can alleviate some of the fear right now and say that estrogen does not cause cancer. In fact, it prevents cancer. We know that it decreases the rates of colon cancer significantly. And what's happening is menopause medicine has become a movement. So I'm happy about that. It's very much in the cultural milieu, but it's not yet in the clinical. So there's a statistic that I think is so powerful that was released from the Menopause Society, which is the organization that is really the most evidence-based in this space that we all follow. And the data, it shows that only 5% of women who need hormone replacement are currently receiving it. So while it feels that everyone is on the hormones and everyone is talking about it, really only 5% are being treated. So you're
Wow.
right to highlight this concern. And I just want to share with people that this is not a concern. Um, so please get your testing done. That will help alleviate just a small bit of the concern. However, I do also want to say your genes aren't your destiny. We do know that even if you have a BRCA gene, that doesn't mean you're going to get breast cancer. If you don't have one, that doesn't mean you're not going to get it. It's just part of the story.
Right. Interesting. Okay. So concierge medicine sounds so ideal. But most women can't access it. So, what does proactive care? What are the three things that a woman who is in traditional medicine should focus on, regardless of price point?
You're not going to like my answer. Um, I don't think you can expect much from the system as it is. So I just want to be honest with you. The only thing you can really do is be your own activist. You have to advocate for yourself. So you need to come to your appointments prepared. Um, it's hard because doctors and patients speak two different languages. So it's hard to know how to connect and what to say at times. But the preparation that I think is required is collecting the labs you've had done, being clear on your symptoms, knowing your past medical history, knowing your family history, having this data collection, and really approaching your doctor visit the way you would approach a visit to your financial advisor. You would come with your files in order. You would have a sort of a rudimentary sense of where things are and where you're starting and where you'd like to get to. But I do believe the doctor-patient relationship is really what's missing, and it's what's been fragmented. And so the onus is on the doctors to reimagine this, and this is what I'm trying to do in my particular practice. But I invite the patients to engage in this process as well, because it's really that partnership, that equality that's going to create a healthier change for patients.
I love that. What have you personally changed about your strategy in your health in the last 5 years? It's a question I like to always ask doctors.
I've changed everything. The glucometer, the CGM, are you familiar with that? That's the glucose measuring device you sometimes see people wearing in their triceps. The CGM was released in 2019, and that was part of the start of my journey. I was running a diabetic retinopathy clinic and looking at diabetes as end stage disease rather than saying, how did we get here? What's your nutrition? That was really somebody else's problem. I was concerned with bleeding in the eye and were we going to laser or inject? So when glucometers came out, which is a small device, you can wear, it's a wearable. Okay, so it's a wearable for the back of the arm. So we call those CGMs. I realized that it changed everything. The patient could now be directly involved in how food or alcohol, anxiety, stress were affecting their glucose on a minute by minute basis. It connects to an app on your phone. So when these were released in 2019, I got a grant to put in 75 of these in patients at a free clinic where I volunteer. And many of the patients were afraid. This was COVID, and they thought maybe the government was tracking them. So I put one in myself to show them, don't be afraid. This is how it looks. It's super easy. And I learned so much from this that this was really the starting point of changing everything for me. So what I learned was I had to stop eating ice cream so frequently. I really needed to give up alcohol. The effect that alcohol had on me in perimenopause was really detrimental. I learned that exercising in nature was more powerful than exercising in a gym. I shifted to a real fundamental belief in exercise. I always knew the numbers. I quoted them to patients, but I really wasn't walking the walk. I was too busy. And I think that I learned agency, which is that we're all too busy. I'm not busier than you, but we have control of our own schedule to a certain extent, and we need to be able to make and find the time within
For
that schedule.
ourselves.
Something else I leaned into is I learned beauty, and that's a funny thing to say. But what I mean by that is, as a physician, I was living in my scrubs. I was rarely brushing my hair. I was sort of not very put together, and I do feel as a profession, we could do better in terms of hospitality, how we show up for our patients. I think that what we're asking our patients to do, we need to be doing ourselves. We need to be modeling that behavior. And I started leaning into that a bit more. I stopped wearing a white coat. I like to say now I wear white leather.
Because the white coat sort of creates a professional authority, but as also a professional distance. And if you're talking about, a relationship, you really want to sort of feel like you're talking to your friend almost.
Exactly right. There's white coat hypertension. Have you heard of that? That's a diagnosis that when you go to your doctor's office, your blood pressure is always 20 points higher because you're nervous once you see your doctor wearing the white coat. That's what we call it in medicine. We call it white coat
I have
hypertension.
never heard that
Yes.
before. And that
So
is,
there's a syndrome related to this relationship, and this is part of the reimagining. Furthermore, it's easy to hide behind a white coat. You don't have to care what you're wearing underneath it.
you can be more clinically distant.
You can be distant, and that's appropriate when you're a surgeon in the hospital. But what we're talking about is outpatient medicine. And this goes back to what I was saying in the beginning. The medicine in America is phenomenal in the hospital. We have the best care in the world. Outside of the hospital, we need to be doing better. So we need to look at what does outpatient medicine look like from all angles? What do the doctors look like? Who are the doctors? Where are they practicing? How are the patients accessing care? Are we communicating still by fax and by telephone? Or can we lean into electronic communication and text messaging? All of these things are changing, and they have to change.
Well, I really, really appreciate hearing your perspective, particularly your own changes that you've made, particularly around what, we can model for all doctors in traditional medicine and concierge medicine about the patient relationship, particularly between for women, which, those kinds of relations are so important. And I really appreciate all of your wisdom, Krista. Thank you so much for joining us.
Thanks for having me.